Good afternoon. I'm Kate Ellis, Director of Research Programming at the National Institute for Healthcare Management Foundation. On behalf of NIHCM, thank you for joining us today for this important discussion on addressing rural health needs. Nearly 1 in 5 Americans live in a rural area, and these communities can face barriers to accessing care. People are generally further from healthcare facilities and other services than those living in urban areas. And rural communities also report poor physical health due to factors such as older age and higher rates of poverty. COVID-19 has disproportionately impacted rural communities and widened health disparities. Rural communities experienced a high death toll due to COVID-19 and have seen lower rates of vaccination as a result of vaccine hesitancy and reduced vaccine access. The pandemic has also exacerbated challenges around accessing care, including through staffing shortages and hospital closures. Today, we will hear from a prestigious panel of experts to learn more about rural health challenges and some strategies to improve health and well-being in these communities. Before we hear from them, I would like to thank NIHCM's President and CEO, Nancy Chalkley, and the NIHCM team who helped to convene today's event. You can find biographical information for our speakers along with today's agenda and copies of their slides on our website. We also invite you to join the conversation on Twitter using the hashtag #RuralHealth. I am now pleased to introduce our first speaker, Tom Morris. Tom serves as the Associate Administrator for Rural Health Policy in the Health Resources and Services Administration of the U.S. Department of Health and Human Services. In this role, he oversees the Office of Rural Health Policy, which administers a range of research and capacity building grant programs that serve rural communities. We're so honored to have him with us today to share HRSA's vision for rural health. Tom?
Hey, thank you very much, and thank NIHCM for hosting this conference and for focusing on rural health. Really appreciate it. With the slides that we'll be using, I'm going to focus a little bit on the federal perspective on rural health, taking a pretty broad view, and then offering a few examples, and then I'll also touch on some of the, setting a context for rural health, and then some of the key issues that we're tracking. So next slide. So I'll start with my office. The Federal Office of Rural Health Policy is located in HRSA, but it has an interesting role in the sense that we're charged in the Social Security Act with advising the Secretary on rural issues, and we have a department-wide focus on rural health issues. But at the same time, we operate a number of programs, as Kate noted, that are around capacity building that very much fit into the fabric of HRSA. And so it's a natural home for us to be there. So we really try to work both across our agency and across HHS and our other governmental partners because, given the challenges we know about in rural communities, we're not going to be able to meet them just with our budget. So one of our approaches is to really work with as many of our partners as we possibly can to leverage more resources on behalf of rural communities. And that's what's great about us being part of HRSA, is because so many of the HRSA programs really do benefit rural communities either directly or indirectly. And so I'm talking about programs like the community health centers, area health education centers, National Service Corps, the home visiting program, just to name a few. But we also have other collaborations going on with the CMS, with CDC, with the National Cancer Institute, and USDA and the rural development programs there. So next slide. So as we think about the federal role in rural health, it sort of takes on a number of different shapes in terms of how it's done. There are obviously a couple of policy levers that are really critical to supporting rural health care. A lot of those are related to payment mechanisms under Medicare, so you'll see special designations under Medicare to take into account the unique challenges rural hospitals have and use reimbursement methodology in order to make sure that they're open, that they're financially viable, and that they can provide access to care for rural communities. At the same time, CMS, through its Innovation Center, has also had a number of demonstrations and payment models, like one going on right now in Pennsylvania that looks at a global budgeting system, all with an eye towards, what might the future hold and what's the best way to sort of figure out how to finance and support healthcare in rural communities. Similarly, public insurance programs, Medicare, Medicaid, the Children's Health Insurance Program, are critically important in rural communities. And if you look at the patient mix of your average hospital, your average rural health clinic, they're much more dependent on those public payers than they are, say, on private insurance. And so that means any change we make in Medicare or Medicaid or CHIP policy has a disproportionate impact on rural communities. With the advent of the marketplaces and the subsidies that they offer, we've seen increases in insurance and beginning to chip away at the uninsured rate being higher in rural communities. And so all these are ways that we're going about focusing on increasing access to care in rural communities. But we also know that access, a big part of it is having the workforce there to do it. And this has been a longstanding challenge in rural communities. And so, HRSA funds a number of grants designed to train future doctors, nurses, dentists, you name it, train them to go out and practice in rural and underserved areas. And then we also have loans and scholarship programs that if they agree to take those, they'll practice in an underserved or rural community in exchange for that support. HHS and the states also will sometimes support foreign trained doctors who will practice in an underserved community in exchange for not having to return to their home country. And they play a really important role in terms of ensuring access to care. Now, more broadly, you have block grants like the Preventive Health Services Block Grant at CDC, or the Maternal and Child Health Block Grant, or the Mental Health and Substance Abuse Block Grants at the Substance Abuse and Mental Health Services Administration. And all of those provide states with tools, and especially for rural states, they can have the flexibility to target those resources to areas of greatest need. Sometimes many of those are in rural communities. And so all of those are really important. And then I think as we talk more about social determinants of health, while people won't necessarily think of our programs at the Administration for Children and Families or the Administration for Community Living as key parts of an approach to rural health, the fact is they are. So for ACF, programs like Head Start and the Community Services Block Grant really play a very important role in addressing those social and human service factors that affect access to care. Similarly, the Administration for Community Living, through its support for programs for the elderly and the disabled, like Meals on Wheels, and supporting area agencies on aging, is another way to get at this. And if you move beyond HHS, you have programs like the Department of Labor that does a lot of employment support through both direct training programs and then the one-stop job centers. The housing and urban development also plays a really important role in terms of addressing housing through waivers in rural communities. And then the U.S. Department of Agriculture, the FCC, the Department of Commerce are now, with the American Rescue Plan, administering a significant amount of money to address the broadband gap. So all of this is a long way of saying that the investment in rural health sort of runs the gamut across a range of federal agencies. So next slide. All right, so I mentioned some of those special payment provisions, and I think this map sort of illustrates the impact of those. What you see here is a map of all the community health centers that are in rural communities, the rural health clinics, which is a payment designation under Medicare, and then the critical access hospitals. There are 1,300 critical access hospitals around in this country, and they play an important role in terms of access to care. And they get special reimbursement benefits by being a CAH, which ensures that that access is supported. The community health centers see people regardless of their ability to pay, and 40% of the more than 10,000 community health center service sites are in rural communities. And you add that in with more than just around 4,800 rural health clinics around the country, and they really are the backbone of the safety net in rural communities. Next slide. Now, all this happens in communities where we have fewer practitioners, whether it's physicians or nurse practitioners, physician assistants, oral health providers. The fact is, and long has been, there's just not enough of them out there to really provide care. We have a maldistribution challenge in this country, and the numbers on this slide sort of reflect that. And while we have a number of programs targeted on it, it's not something that is addressed overnight. I am heartened though by a number of new approaches, and I'll mention one real quick. We've been supporting the development of more rural residencies in rural communities through a new grant program we have, because we have data that shows that, particularly for family medicine, you're twice as likely to practice in a rural community if you do your final training in a rural training track. So for the past 3 years, we've been investing in growing the number of rural residencies and taking advantage of some flexibility in the Medicare law that allows new residency programs to be started up in rural communities and not be subject to the cap on Medicare supported rural residencies. We know state Medicaid programs are also doing more in terms of supporting this. So this is one part of a larger strategy, I think, that could help to address these issues. Next slide. Now, the challenges are even more daunting, I think, in terms of access to mental health care, in terms of the number of practitioners out there. We have 250 rural counties in this country that do not have a psychiatrist or a psychologist, a psychiatric nurse practitioner, a licensed clinical social worker, or even a mental health counselor. And so that means the burden falls on top of primary care providers. Unfortunately, sometimes it falls on behalf of the criminal justice system. But it's a really longstanding and challenging situation to address. I am heartened by the fact that of those residency programs I just mentioned, 6 of the ones we've supported so far are for new psychiatric residency programs in rural communities. And the hope is that they can be an important pipeline moving forward. And then a relatively new program in our Bureau of Health Workforce at HRSA, the Behavioral Health Workforce Education and Training Program, or BWET, is also starting to chip away at this also. Next slide. So, given all that, I think most people are aware of some of the challenges that rural communities face, and none of these should be surprising to anybody. But obviously, rural women have higher maternal mortality rates. We have higher rates of chronic disease. We have greater distance to care, particularly for specialty care. All this adds up, to some structural challenges that have been in place for quite some time. Next slide. So given those challenges, it's not a surprise that rural people tend to die at a higher rate of avoidable or excess death in the 5 leading causes of death, whether it's cancer, heart disease, injury, mostly driven by opioids, respiratory disease, and stroke. Next slide. And the mortality gap is interesting. We had a study a couple of years ago that attempted to look at, well, what was driving the gap between it being higher in rural areas relative to urban areas. And what they found was the drivers were virtually the same. It's just that for whatever reason, they're more determinate in rural areas. And so, the challenge is, what do we do about this? I know that when you look at this from a national level, how do you move these metrics? It's very, very challenging. And yet, I know from our own investments in rural communities, very modest investments, that you can empower local towns and areas to address these issues. And last year, we launched a new initiative called Healthy Rural Hometowns, designed around addressing the risk factors associated with those 5 leading causes of death. It's a small step, but we're hopeful that it will show results and that we might be able to then ramp it up more dramatically in the years to come. Next slide. I think we also have this stereotypical vision of rural America as being largely white and elderly, and there are certainly parts of the country where that is true. And yet, as we think about health equity and equity, we have to realize that there's no monolithic view out here. And the fact is, rural communities are diversifying just like urban communities are, maybe not at the same rate, but they are diversifying. And I think this slide, which is from a Brookings study that was released a few months ago, really details this wonderfully, in the sense that the more yellow you get in these slides, the higher the rate of diversity in the population. And the reason I wanted to mention this is because I think it does factor into how we think about solutions, that we have to think about a more diverse population than we did, say, 10 or 20 years ago. Next slide. So let's talk about some of the challenges that are front and center for us. I think number one, obviously, is the opioid crisis. We know that in the past year, the mortality rate from overdose death has increased. It's increased both in rural and urban areas. The opioid crisis is particularly challenging in smaller communities because they often lack the clinical infrastructure to really deal with it. And then geographic isolation can add to it. And we've been lucky since 2018, we've had a rural community opioids response program, which is giving money directly to communities to create networks of care to address the opioid epidemic. But there's no doubt that during the pandemic, as people in recovery were in isolation, it made it much harder to provide services. So the overdose death rate increase should not be surprising, even as it is disappointing. And so while many of our grantees went to virtual care, it was not a perfect solution for the way to deal with this challenge. And we're hopeful, as we move on to the next phase of the pandemic, that we can get back to continuing to try to turn the tide on this one in particular. Next slide. So we mentioned the impact of the pandemic and COVID-19 at the outset of the presentation, and certainly, it has hit rural communities in a dramatic fashion, and already has been noted, lower vaccination rates, higher case rates, higher mortality, all of which, is a real concern for rural communities, and it's happened at times with less clinical infrastructure, which has overwhelmed many rural hospitals and many rural clinicians. And so, to the administration's credit, when the American Rescue Plan passed, it didn't have anything specifically targeted to rural in the HHS budget, but the administration decided to spend almost $1 billion to support testing and mitigation efforts in rural health clinics and small rural hospitals, to support a vaccine confidence program for rural health clinics. And we also began initiatives to directly distribute vaccines to rural health clinics, community health centers, and to do testing supplies to both of those entities also as a way to begin addressing some of this. Next slide. Now, Josh will talk a little bit more about this. I won't go into much detail, but I think most people know we've had a rash of rural hospital closures. And the reasons for this are multifaceted. There's no one thing that's driving rural hospitals to close. Part of it is loss of population. Part of it is a challenging payer mix. Some of it may be market consolidation. There's no single solution to this challenge. And we've been tracking it as part of our policy role pretty actively, but particularly since 2010. And during that period, we've had 138 rural hospitals close. So, I think there's no single solution to this one either. And yet, while we have a number of programs to support rural hospitals around quality improvement and performance improvement, we are also tracking closely on a new designation that the Centers for Medicare and Medicaid Services will do rulemaking on this year to create the Rural Emergency Hospital, which will be basically a rural hospital with no inpatient beds. We don't know what the take-up of this will be, but we suspect that it'll be an important option for communities perhaps that are not big enough to support a full-service hospital, but that need more than a clinic. And so we'll see what happens with this moving forward. Next slide. We're also facing a maternity crisis and an obstetric crisis in many rural communities. More than half of rural counties do not have hospitals that offer obstetric services. And those gaps are particularly pronounced in communities of color. And so you look at this map, the darker the red, the more serious the challenge that we have out there. And again, a number of factors are driving this. We are trying to fund some new projects to get at it. We have the Rural Maternal Obstetrics Management Strategies Program. We began this as a pilot with the idea of working regionally and linking together community health centers, rural hospitals, nurse midwives, Healthy Start grantees, home visiting programs, rural health clinics with upstream tertiaries using telehealth. And we require Medicaid to be part of the network approach that we're using here, with the idea being that if we can improve access and we can improve outcomes, we can also save money on the Medicaid side. As we do that, think about it, if you just avoided one neonatal intensive care stay unit in a state, you'd basically pay for the entire grant. So we have 6 pilots out right now, and when the budget passes, we'll be moving to have this be a permanent program funded at about $10 million a year. And so we hope that that will help, at least in some communities, begin to address this challenge. Next slide. And then finally, just a quick word about telehealth. I think Josh will cover this in more detail, but obviously, it's always been an important tool in rural communities. What I think we've seen during the pandemic is it's an important tool not just in rural communities, but in many urban communities as well. And reflecting that, the telehealth programs all used to be in my office, but they've since moved to become a standalone office in HRSA. And they really are a focal point for telehealth activity HHS-wide. They led efforts to create a single website point of entry for telehealth issues at HHS, and you can see the address for that webpage on this page. They're also tracking very closely and working with the Department of Commerce on its implementation of a really record amount of money to address the remaining broadband gaps in this country. And so with that, I've included a couple of more slides of interest. Obviously, I've covered a lot of ground in a very short period of time, so please feel free to follow up with me on any of this if you have any other questions. But with that, let me turn it over to Josh. Thank you.
Thank you so much, Tom, for sharing more about the state of rural health in the United States and highlighting some of the key challenges facing rural communities and really sharing the federal approach to reducing disparities and addressing the workforce challenges. Next, we will hear from Josh Jorgensen, the Government Affairs and Policy Director at the National Rural Health Association. The association provides leadership on rural health issues through advocacy, communication, research, and education. We're grateful Josh is with us today to share more about rural health needs, digital equity, and their efforts to support rural health across the U.S. Josh?
Great. Well, thank you so much for having me this afternoon. Really appreciate being here and having this conversation today. So we'll go ahead and get started. As mentioned, I'll touch on, a little bit following up what Tom said on what the rural health safety net status looks like, and then some of the work we're doing on digital equity and telehealth work at NIHCM. So next slide. just a little bit more about who NRHA is. NRHA is a national nonprofit membership organization of about 21,000 folks nationwide. We make up a large majority of critical access hospitals, rural health clinics across the country. And my job for the association is to do advocacy on work out here in Washington, which is where I'm based right now. So next slide, please. Just talk a little bit more about the rural landscape. Next slide. So quickly looking, Tom did a really good job pointing this out, but when we talk about rural, we're talking about a vulnerable population going into COVID-19, certainly has been exacerbated throughout the pandemic. Additionally, we've seen systemic workforce shortages, kind of crippling rural communities and providers for years, but as with anything in workforce and in healthcare over the last year or two, it's been exacerbated, and you have that scattered population that has longer drive times to get the care they need, and hospitals that are closing at unfortunately large numbers, limited resources for providers, and we do have inadequate Medicare, Medicaid, and private insurance coverage, and that lack of Medicaid expansion in a lot of states as well still has kind of hurt that rural health safety net, and led to some unfortunate closures and more hospitals being vulnerable for closure. So next slide, please. Tom spoke on this just briefly, but since 2010 in particular, we've seen 138 rural hospitals close, and that's up this month. And you can see really where they're located, unfortunately, is in that southeastern part of the United States in particular. However, on the good side of things, what we have seen is that in 2021, we only saw one rural hospital close. And you can kind of look through the reasonings, but the real true reason is a lot of the support that came out of Washington, D.C. over the last few years for things like the CARES Act or the American Rescue Plan has really kind of helped lift that rural health safety net. And part of our job here at NRHA is to see that support continued beyond the pandemic and ensure that we kind of see stabilities in this rural hospital closure crisis. So next slide, please. This is the number that I think is particularly concerning when we talk about rural health, and that's the 453 rural hospitals are vulnerable to closure. So what does that mean? That means they're operating at margins that are similar to those who closed over the last few years. And again, where you see that, you'll see that the overlap is in a lot of states where we already see that high number of rural hospitals that have closed. And it's not just closures that are concerning for rural communities. It's services leaving the community as an alternative, right? So to try to stay open, maybe a service will leave a community, and that leads to a lot of the unfortunate situations that Tom was discussing, where you might have, maternal outcomes deteriorate or mental health outcomes deteriorate. So improving that rural health safety net's really critical, and a lot of the work that we're doing out here in Washington to try to, curb that trend. So next slide, please. This just shows the population health disparity that Tom was discussing just a little bit more. So what we see is over 65 graphic here for percentile. Rural is higher when it comes to that population. We have a higher prevalence of chronic diseases such as diabetes. Additionally, there's a lower household median income, lower access to primary care, and lower access to mental health care. So just kind of that whole situation, breeds a unfortunate outcome for the rural health safety net at this time. And next slide, you'll see that where the safety net is the weakest is you see it in those hospitals that have or in a community that has a hospital vulnerable to closure. So you'll see lower access to primary care in those vulnerable communities, lower access to mental health. You'll have higher amounts of uninsured adults, higher amounts of uninsured children, and a higher prevalence of premature death, which is, disturbing, but it happens in those communities where you have a hospital vulnerable. Fortunately, as Tom said, there is this new rural hospital designation, the rural emergency hospital, that we do hope will be a lifeline for a lot of these hospitals that are vulnerable to closure or potentially looking at closing their doors to stay open for their community and ensure that we do have that continued access to care. Next slide, please. And here, just one more slide, just showing the prevalence that we've seen in population over 65. We have a higher prevalence of veterans, child poverty, diabetes, premature death, and unfortunately, we have lower access to primary care, dental health, as well as mental health services in our rural communities compared to our urban and non-urban rural counterparts. So next slide, please. So now I'll get to talk about what I consider kind of the upside of all this that's happened throughout COVID-19, which is the advancement we've seen in telehealth and broadband services largely over the last couple of months. So next slide, please. So telehealth during COVID-19, when we talk to providers at NIHCM, a lot of times what we'll hear is that, they've been doing telehealth for a long time. It just took a while for policymakers out here in Washington to kind of work on it and advance it. So at the onset of the COVID-19 pandemic, we saw passage of the CARES Act, as well as some movement from the administration through the 1135 waiver process. And that largely expanded telehealth virtually overnight. It allowed for telehealth services to be provided by federally qualified health centers and rural health clinics through the 1135 waiver process. Critical access hospitals were brought into the fold, as well as reimbursement for things like audio-only services, which is critical. Unfortunately, though, almost all notable telehealth provisions are tied to the end of the public health emergency now. We can debate when the public health emergency will end, but I think a lot of folks would agree that it's probably closer to ending than it was to the beginning of it, meaning that, we're really starting our advocacy to, look at the true silver lining, which has been telehealth and what it's allowed for communities, and ensure that it's extended beyond the public health emergency, so that way providers and patients in rural communities are able to have that increased access to care moving forward. Next slide, please. That said, rural utilization of telehealth hasn't always been at the same level as we've seen in our urban and suburban counterparts. So according to a recent report, Black and rural beneficiaries had a lower utilization of telehealth compared to white and urban beneficiaries. So why is this broadly? First of which is broadband accessibility and availability in communities. And then secondly would be provider readiness and infrastructure there. So next slide, please. When we look at the digital divide in rural America, essentially what we'll see is that rural communities have a lower availability and accessibility to broadband infrastructure at this time. However, the broadband infrastructure bill that just passed Congress last fall and was signed into law by President Biden does provide about $65 billion for broadband connectivity and really good nods to rural communities to ensure build out in our communities. But we are aware that that will take some time. So next slide, please. We're really looking at this as kind of a lifeline, but we understand that the lack of broadband access that we've seen over the last few years, does have, does hurt health outcomes, So according to the Robert Wood Johnson Foundation's area with limited broadband access also have higher rates of chronic diseases, resulting in a double burden. So having that broadband access, isolation causes, worse health outcomes. So it's really critical that Congress and the administration ensure that it's, built out in a manner to ensure these communities have access moving forward. Next slide, please. On the provider readiness and infrastructure side of things, broadband's huge. We don't go, 5 minutes without talking to a provider until broadband access comes up. But another is hesitation to invest in the infrastructure needed to have telehealth and telemedicine, mainly because all these provisions are tied to the end of the public health emergency. So, you have rural providers that are vulnerable to closure or are operating on super thin margins. They might not be willing to invest in something that is simply looking at coming to an end in April or July. So that's why we're really saying to Congress, telehealth needs to be here to stay. We need to make that signal to folks, but also to the extent possible, ensure that capital investment funding is also there. So that way folks who might not have wanted to invest right away or who are still hesitant have the ability to be part of that 21st century healthcare delivery system, and also ensure that audio-only language continues. So that way beneficiaries who might not have broadband connectivity are also able to connect. Next slide, please. So being out here in Washington, just wanted to quickly touch on a few pieces of legislation that we're looking at bipartisan. There's a ton in this space, but a few just to note. First is the CONNECT Act. This is a comprehensive telehealth bill that provides a lot of extensions of the CARES Act language, but it includes permanent extension of language for rural health clinics and federally qualified health centers, but it does it at an updated reimbursement rate. So it allows payment parity between in-person and virtual visits, which is extremely, something we're really looking forward to or hopeful that will be included in legislation that gets across the finish line. Telehealth Modernization Act is a bill which, essentially copy and paste what was in the CARES Act and makes it permanent with no modifications. There's a bill called the Protecting Rural Telehealth Access Act. This also allows for payment parity for audio-only health services, and it brings folks like critical access hospitals into the fold through legislative text, so that way all rural providers are able to be part of telehealth moving forward. And then lastly, a bill that was just introduced is the Telehealth Extension and Evaluation Act. So this is a 2-year extension of telehealth services. So as you can see, there's a ton of pieces of legislation on this and a lot of debate as to what's happening moving forward. Us at NIHCM are just hopeful that Congress moves, the telehealth extensions beyond the public health emergency and brings all rural providers into the fold at a reimbursement level that's close to, or if not on the same level as in-person care. So that way all rural providers are able to be part of that. Next slide, please. So when will telehealth flexibilities be extended? Our hope is that this will happen in this upcoming appropriations package going through Congress. Currently, the federal government's operating under a continuing resolution through March 11th. So we're hopeful that it's an omnibus package and will allow for non-appropriations riders to be included. And with that, we're really hopeful that this silver lining, which is telehealth, can be extended beyond the public health emergency, so that way rural providers and rural beneficiaries are able to continue utilizing telehealth services. Next slide, please. So here's my email. Would be happy to talk with anybody after the call. So thank you again for having me, and I will pass it along.
Great, thank you so much, Josh, for highlighting the rural health safety net, the importance of digital equity, and really the role of and challenges around telehealth. Next, we will hear from Dr. Creshelle Nash, Medical Director for Health Equity and Public Programs at Arkansas Blue Cross and Blue Shield. Dr. Nash provides leadership on programs to improve health equity and address health disparities in Arkansas's most vulnerable communities. Her work to improve health for all Arkansans includes her role in the Vaccinate the Natural State Initiative, a collaborative effort to ensure equitable COVID-19 access and distribution. We are so grateful to have Dr. Nash here today to share Arkansas Blue Cross and Blue Shield's efforts to address health disparities in rural areas. Dr. Nash.
Thank you. Thank you. And thank you to the audience this afternoon. Thank you to NIHCM and thank you to my colleagues on the panel who have set me up very nicely to talk about rural health as health equity, as a health equity issue. And since they have done a good job, an excellent job actually, of setting the context, I'm going to be leaning in really to the local effort to talk about our experience at Arkansas Blue Cross Blue Shield. If you would go forward to the next slide, please. In terms of the intersection of rural health and health equity, and really talk about our activities through multiple lenses that includes leadership, partnership, data-driven education, and hopefully in my brief amount of time with you this afternoon to talk about implications and takeaways. Next slide, please. So a bit before we begin about the context of Arkansas and COVID-19 for me, I think my colleagues have done a good job in setting up some definition or some terms that we have talked about and you've heard quite frequently in the media, and that is health equity and social determinants. And I just want to be clear before I begin what we mean by that. And many of you on the call know this, so forgive me for repeating the obvious, but the definition that I use for health equity is that health equity means that everyone has a fair and just opportunity to be as healthy as possible. And that really means removing barriers, right? It means removing poverty, discrimination, powerlessness, poor access to jobs, all that stuff in addition to healthcare. So with all those lofty terms, what does that mean? That really means that when we are talking about improving the health of communities, we also have to give special attention to those who are at the greatest risk of poor health based on those social determinants. And what are those social determinants? Well, you know, that definition we also hear is where we live, work, and play and pray. Well, that means the context of people's lives. That means safe housing. That means transportation. That means tackling discrimination and racism and violence and education and all those different things. So that's kind of the definitions that I want to be clear on as I start. Now, in my context of Arkansas, I'm going to share with you a little bit of a personal context. I was born at 28 weeks in rural Arkansas, shortly after hospitals were desegregated. I have many memories of spending summers with my grandparents in rural areas in the country, you know, with family and a resilient, tight-knit community. And I have wonderful memories of a natural environment that's absolutely gorgeous, and it still is. And we still have our challenges. Our challenges in Arkansas right now are for state health rankings. We rank 46th in the nation. We have expanded Medicaid, but we have a long-standing issue with racial and ethnic health disparities. And as you've already heard from my colleagues previously, the challenges of rural health and healthcare access and the impact of the pandemic itself. Go forward, please. Next slide. So when I think about health equity leadership, as I stated, we have a long legacy, not only in Arkansas, but in the United States as a whole, of systemic and structural racism that influences socioeconomic and social determinants of health, those resources, the distributions of those resources, including healthcare resources that ultimately result in racial and ethnic health disparities and rural health disparities. The COVID-19 pandemic has presented a renewed opportunity, I think, to address these in all of its dimensions. And many of you on the call have been working in this health equity space for decades. We know what some of the solutions are, and it's just now we have an opportunity, I hope, all the way upstream to the policy level to actually make some improvements, long-term systemic improvements. So in my role in leadership, some of the things that I am able to do is champion health equity across the board, increasing the knowledge across the continuum. And when I say continuum, what I mean by that is not only within the healthcare system in terms of healthcare quality and healthcare access, but also linked to those social determinants of health all the way upstream to programs and policies that we as an organization have and partnerships in local communities. And in that, I'm developing, implementing, and attempting to evaluate health equity initiatives so that we can ensure that all persons have an opportunity to be healthy. Next slide, please. So my colleague made a comment about moving the needle. That's a good question. All of these issues have been around for a long time. How do we move the needle? I think that data is foundational for the identification and measurement to have a health equity impact. And what that means right now for us is the collection, not only the collection, but the utilization of race, ethnicity, and language data and urban versus rural status as we identify health equity or health inequities to address. We also have to have an internal stakeholder assessment such that we can know where we are as healthcare organizations or as organizations in general. The health equity framework really has to be infused across all internal silos. And that's what we're attempting to do. I'll give you some examples of that in a moment. And external stakeholder engagement. And as you heard from my colleagues, really a cross-sector partnership. You heard cross-sector partnerships from the federal level across the federal government. Well, the same thing needs to happen to address these complex issues in local communities. Next slide, please. So Arkansas Blue Cross Blue Shield has a number of priorities that I have listed here, but the point that I want to make is that health equity is not another silo to be addressed. Health equity is actually infused in all of our priorities, and some of them you see here in our COVID-19 response. Through the Blue and You Foundation, we've awarded 2 rounds of rapid response grants out in local rural communities, and that could be everything from healthcare providers, offices, to food banks, to mobile units, to providing personal protective gear during the pandemic, and media campaigns. When we're looking at maternal health, while we are looking at maternal health as a whole in Arkansas and how we as a health plan are value added not only for our members but for the community as a whole, we also have to address Black women's maternal mortality. With the National Blue Cross Blue Shield Association, we are a part of the strategy to reduce the mortality rate by 50% in 5 years. Big, hairy, audacious goal, but equity, that is equity. We also have initiatives in behavioral health and in the rural health space specifically. The Blue Cross Blue Shield Enterprise donated significant funds to upgrade digital health networks in Arkansas's rural hospitals. Next slide, please. So what does this look like if I'm leaning into and trying to describe to you work where the rubber meets the road? How do we advance action through leadership, through partnership, and through data-driven education? First, I will say, as Medical Director for Health Equity, I'm always at the table, at multiple tables, I would say, trying to ask the right questions. And when I say what the right questions are, it's what are the barriers that we need to address? Who are we missing? What are we doing to address health equity specifically? And are we making health equity worse in what we are doing, in our policies and our programs? And then what can we do to mitigate that? Also breaking down internal and external silos. And so for me, in terms of the health plan or a health plan, that means that health equity has to be infused across multiple silos, whether we're talking about utilization management, case management, disease management, quality management, population health. In partnerships, we've heard about partnerships at the federal level, and in DC. I want to highlight partnerships at the local level, those cross-sector partnerships. And one of those I want to highlight is the listening sessions that we have been having in local rural communities, specifically with minority mayors. Just had one last week, actually, with some awesome African-American women who happen to be mayors of their local towns. And we've heard many things from them, in addition to an update from COVID-19 and what's going on in local communities. We still hear things about clean water or lack of clean water, lack of sanitation, lack of transportation, lack of digital access, and behavioral health services. So when we have these conversations, it's a combination of the elected officials, minority healthcare providers, federal FQHCs, and we're trying to form and build a true partnership where the voices of those who are most impacted are at the table, not only to define the problem, but to define the solution. And these conversations don't stop at conversations. As my colleague said, we have to bring resources, partnerships that bring resources and empower communities to solve their problems. So the other, now I've given you a little bit about leadership, a little bit of an example of a partnership, and I want to focus just briefly on the data-driven education and what I mean by that. We are working to collect and utilize race, ethnicity, and language data and urban versus rural status in our quality measures. That helps us determine where those gaps are, where those inequities are, and find with communities solutions to meet those needs. And one example of how we have done that, and I'll give you some information on that, is focusing in the Delta region in COVID-19 in our Vaccinate the Natural State. Next slide, please. So this is what I'm calling a data-driven case study. As you know, the pandemic has been a roller coaster ride for all of us, including the state of Arkansas. Right now, we have 800,000 Arkansans plus who have been diagnosed with COVID-19. Over 10,000 have died to date. And right now, we have a vaccination rate that is about 55% fully vaccinated. And just as you've heard from the national level, here in the state of Arkansas, Black and Hispanic Arkansans are at a higher risk and continue to have a disproportionate impact of COVID-19. In that context, Arkansas Blue Cross Blue Shield has invested in what we call Vaccinate the Natural State. And that was an overall effort to educate and provide access to vaccines and resources. There's a business-to-business component, but there's also a community engagement component. And in that community engagement component, health equity is infused from the beginning intentionally. And with that intention came a focus on the Delta regions, rural regions of the state of Arkansas. This partnership really is a community health worker model partnership where we have partnered with the Arkansas Faith Network, with the Arkansas Medical, Dental, and Pharmaceutical Association, which is a multidisciplinary organization of minority healthcare professionals, and the Arkansas Department of Health Office of Faith-Based Outreach, to provide a community health worker service to local churches who not only care for their communities, but for their congregations, but also their communities at large. And we do things like lunch and learns to provide updated information, having vaccine events, vaccine efforts, and to foster coordination and collaboration and build capacity in local communities. Because there are many organizations that are focusing on the Delta at this time, and we all need to come together and show collectively what we can do to address health equity. So if you go to the next slide, what I'd like to show you is something that we have been doing to keep health equity on the agenda across the board in health equity. And this is what I've called a data integration dashboard. It's a Tableau dashboard in collaboration with the Arkansas Department of Health, who has stratified vaccine uptake by race and ethnicity. And we have integrated multiple databases to look at that by race and ethnicity, by county, by social vulnerability index, and that's the CDC's index, but also overlaid on top of that COVID-19 treatment sites. And as you know, that has been a ever-changing effort, whether you're talking about monoclonal antibodies or antiretrovirals, and hospital capacity. So all of this is culminating together to help us identify and focus health equity on health equity. And what I want to point you to on this slide is that if you can see, the blue counties are the ones that have a 50 to 60% vaccination rate. And those are in some of our most rural counties with the highest minority or Black, Indigenous people of color in Arkansas. And you can see we've made some headway there. We have the upper Delta to go, but we're also pivoting to make sure that we have that equity lens on treatment sites. So if you hover over one of the treatment sites, you have a phone number, you have what's available through the distribution of the health department for treatment in these areas. And we're using this to get support for collaborative efforts across the state of Arkansas to officially and formally address health equity. Next slide, please. So I know that was a lot of information in a very short amount of time, but if I could sum up implications and takeaways, I think I would say that the intersection of BIPOC or minority health and rural populations is an equity issue. It's a personal issue for me because it's where I come from. It's what produced me. It's an issue because I'm a healthcare provider and I commit to taking care of individuals and communities. but it's also a strategic, and it's a business decision too, because to improve the health of our population and to decrease healthcare costs, equity must be a part of that. Arkansas Blue Cross Blue Shield has made health equity as a priority through those multiple lenses that I went through with you very quickly, through leadership, through partnerships, through education and data, really to drive and facilitate collective action. I think that health plans and healthcare organizations really have to be a part of the solution in partnership, in true partnership with local communities. And health equity has to be infused across all functions. And this is not only for COVID and COVID-19, but really we are pivoting with these partnerships to COVID and beyond. So if you're talking about maternal health, if you're talking about behavioral health, if you're talking about diabetes, these are the same core things. And we have an opportunity in this crisis to make significant investments across the nation to improve health. And we have a lot more work to do, and that work includes all of us. So with that, I'll stop there and say thank you. Next slide.
Great. Thank you so much, Dr. Nash, for highlighting the intersection of health equity and rural health and how Arkansas Blue Cross Blue Shield is prioritizing health equity using data and really developing solutions in partnership with the community. So we'd like to use the remaining time to engage in a Q&A session with our audience. Please continue to submit your questions in the Q&A tab. We are working our way through those. I will ask our panelists to come off of mute and back onto video. And I will pose our first question. I'll open this up to everyone. We had a few questions actually come in around the disability community and how we can better support families with disabilities in rural areas that often have a unique or different set of needs. We'll see if anyone is able to take that. Okay, we can move on to another question. We did also have some questions come in specific to the older population and really thinking about telehealth and the disparities in digital access. And I know, Josh, you shared a slide highlighting some of those disparities. Can you speak to any of the kind of other innovative solutions for helping older adults access digital resources, online resource directories, or different partnerships that you've seen in place to really help those individuals access care in this digital world?
Yeah, thank you. You know, I think when we talk about the older Americans with telehealth, I think first thing that comes to my mind is the need for the continued audio only. I do think that you're talking about a population who just might not have the wherewithal or understanding of using these technologies right away. But then, moving forward, what do we look like? I think something, and this goes to working with, the local level, it would be digital literacy classes to ensure folks know how to use things like Zoom or FaceTime and these technologies that are being entwined into our healthcare and our daily lives. So I think it starts with making sure audio only is here for the foreseeable future, not only for the broadband access, but also for the folks who might not understand it. But then moving forward, providing teaching opportunities. I don't know the exact entity that would want to do that. Maybe it's health systems would be able to help work with some of their older individuals who they're giving care to, or it's folks in the communities. But I think that needs to be part of it for sure.
And I think the only thing that I would add to that is, I have personal experience with this with my mother, who is 74 years old and had her first telehealth visit, and I had to be there with her. And what we learn and what the digital solutions that we are trumpeting are great, and they're there, but it can't be an either or. For example, we have some communities out there that are using community health workers to help people connect digitally, whether you're at a local library or somewhere where you have free Wi-Fi. So there are lots of ways to get at this, but you have to be aware of where the gaps are. And I think that that's one of them. And a community health worker model, it can't be either or. It's gonna have to be a part of that to support communities at risk.
Great, thank you. And Dr. Nash, we actually had some questions come in around community health workers, so I'm glad you were able to raise that as another access point for individuals. On the topic of COVID and the pandemic, we had some questions around COVID messaging in rural communities. And if any of you could speak to kind of any advice, especially as we're transitioning to we're seeing this major lessening of mitigation measures, we're seeing mask mandates change. If you have any advice or resources as people are grappling with some of the messaging challenges.
Oh, it's been, I'll start out and I'll leave time for my colleagues. It has been a moving target, definitely, as we move through the pandemic. As you know, we are flooded with lots of information. And so how do you get a message that cuts through? I think that one of the key tenets that I will say is that the messenger matters. In local communities that I deal with, we have to be willing, the person that's going to deliver the message has to look like the community that we're trying to reach and actually speak the truth of what we know and what we don't know, and be willing to answer and talk about the hard questions, which is lack of access, which is in some cases discrimination and not trusting the healthcare system. We have to be able to have those tough discussions and be ready for those.
Yeah, I can't agree more. I think one of the most important things is what you said, which is the messenger really matters, and it needs to be somebody who's trusted by that local community, and that needs to be, defined. And folks who are, out here in Washington or in state capitals across the country who are trying to, increase this vaccination rate need to work hand in hand with those, trusted local leaders.
Great, thank you.
And that includes minority healthcare providers if you're trying to reach minority populations.
Yes. We did have a specific question come in. I believe this was a map, Josh, that you pulled up showing kind of the closures, and the closures, this individual wrote, the closures seem to be closely related to states that have not expanded Medicaid. Has this been evaluated? Can you share just some of your thoughts on or any information you have on the research around that, or if you think that is accurate?
Yeah, I can give a quick stab at it. And if anybody wants to speak to it, I think it's certainly, when we look at the 453 hospitals that I showed where, there's the ones who are vulnerable to closure, we often talk about, the higher uninsured rate being part of that reason for vulnerable to closure, and closing that coverage gap would certainly help in a lot of these states. And you do see, the states that haven't expanded Medicaid, do have that higher number of hospitals that have closed in rural communities, and they also have a higher prevalence of, hospitals vulnerable to closure. They've done some really great research at this with UNC, North Carolina's done some research, as well as Chartis, and I'd be happy to share that with you, Kate, and we can just, disseminate that after the call.
Great, that would be fantastic. Yeah, we're happy to put up additional resources for many of you on our website so that people can access that after the event. One question that I'll kind of open up to everyone. It seems like there is no single solution to improve health equity in rural America. We've seen questions coming around LGBTQ health, Native Americans, disability, a lot of subpopulations. And so people are really grappling with this challenge. So kind of in your opinion, what do you think is the most critical or urgent to do? Or what would you kind of send our audience off with kind of as something they could start tackling immediately?
I'll start.
Big question. Big question.
I'll say it's not a single, as you pointed out, it's not a single solution. For me, it's about championing equity across the board, even when the spotlight goes away, because the spotlight is going to go away again, right? And how do we maintain this effort go forward? It's got to be partnership, cross-sector partnership. The healthcare system, as we know it, can't do it. The things that make you sick happen outside the healthcare system. So we have to have unique, new public-private partnerships that get upstream to the policy level. And finally, we have to evaluate what we're doing so that we can scale up quickly or fail quickly and move on.
Yeah, I think that's absolutely correct. And, I think one thing that Tom said, early on is that, rural America is not just, elder individuals who are white. There's, folks who are African American, Hispanic, LGBTQ, et cetera, in all these communities and throughout all the different ages. So, understanding that there's a really big population cross section between both health disparities as well as those ethnic and racial disparities in our rural communities, and first looking at the data, as Dr. Nash said, and understanding what it is, and then creating those partnerships all the way up to Washington and to the various state capitals.
Yeah, I would agree with all that. I mean, I think the Brookings study that I referenced was really informative because it was the most current data. And even in our smallest communities, we have divides where sometimes all the people are not at the table. And until we have all the folks at the table, you really can't begin to address these. We can, so often I think we fall into the trap with like looking at disparities and might look, we're happy, traditionally we've been happy when they just look at, not at the national or state level, but they include a rural urban cut, but even that's not far enough. If we don't then go down and look at sub-rural and look at different racial and ethnic populations, we could miss an entire dynamic and then come up with a solution that only benefits one portion of it. So I think the solutions start locally, but we've also got to encourage folks and create incentives to bring everybody in and to look at the full range of populations you're serving.
Great, thank you so much. Unfortunately, we are out of time today. I'd like to thank our excellent panel of speakers for being with us, for sharing their work, and for our audience joining us for this important discussion. Your feedback is important, so please take a moment to complete a brief survey that will open at the bottom of your screen after the event. And check out our website for additional resources, including our recent infographic on rural health. And we'll be sure to link to other resources that the panelists mentioned during their presentations. Thank you all for joining us today.